Thanks and good morning. I'll try to make a topic that can sometimes seem dry, hopefully interesting, because there's going to be some policy mixed in here. And I just want to start with saying that I am not a policy wonk in any means. I've had to kind of distill this in a simple form in a way that I can actually understand to be able to present it. Start off with this quote I think kind of speaks to this problem, right? Just price is what you pay, but value is what you get. And that's our challenge in healthcare. And what I want to do today, hopefully, is define for all of us what value-based care means, review U.S. policy evolution that's leading to value-based payment models, examine some real-world examples where we're implementing value-based care, specifically in otolaryngology, and my own personal experience at the Permanente Medical Group, challenges we face as a specialty, and then future directions. So we all know this is a trajectory, right, for healthcare spending in this country, which is just goes up and up. Year over year. This is the percentage of GDP spending on healthcare in our country. And there is a dip there after ACA was enacted and then along with COVID, but it's going back up. So here, this is comparing 2022 to 2023 costs from CMS, and everything went up in 2023, right? So healthcare spending at the hospital level, physician and clinical services, drug prescriptions, and it's continuing to go up. I don't have data for the last 2 years because they haven't published that, but you can see the spending is just right back on track after COVID going up. And I'm sure you've all seen slides like this before where, here we are with spending, right, on the x-axis. U.S. is way out there compared to all the other countries in the world, including developed countries, and then our life expectancy is lower than others. So we have a problem here where we're spending a lot, but maybe not getting all that value and quality of care maybe. Or there's other factors, of course. There's big issues here well beyond this talk about why, as a country, we have such a problem with healthcare. But just to give an example, a little bit of work I did in this area, looking at our fee-for-service model and the issues there. So published this paper looking at balloon sinuplasty, and there's been lots of papers since this one, but showing how there was this just explosion in balloon sinuplasty in the office, right? Once there was a CPT code developed for it that reimbursed very well, and in fact reimbursed better than OR procedures. And what we looked at, this was looking at the Medicare population, the CMS database. We found that providers were doing this who were never billing for sinus surgeries, right? So you had ENTs who, in their practice, never did this, but now all of a sudden was doing this a lot in their office. So it gives you a sense of the flavor, right? As maybe people who weren't necessarily having a very heavy rhinology practice, but now with balloon sinuplasty was offering this procedure. And the question is, did we really find something here that was going to be the cure-all for chronic sinusitis? Was this really superior to everything else we've been doing? And that's, studies weren't really showing that, right? It's just that this was a great way to start billing for a procedure. And so, there is this, disconnect, right, between spending and outcomes that we're often seeing in the fee-for-service world. And that's what's primarily driven this payer reform that we're seeing in our country. And so what value-based care is trying to do is close the gap between the resources that we're spending and then the outcomes that are being achieved with that. So this book, Redefining Healthcare, Creating Value-Based Competition on Results, written by Michael Porter and Elizabeth Olmsted Teisberg. It's probably the most cited book about value-based care. If you read about it, they're kind of the thought leaders in this. Michael Porter is out of the Harvard School of Business. And he's not a physician or anything, but he really focuses on sort of the economy and concepts of where competition is at different industries and how competition drives outcomes. And so his and her hypothesis is that the core problem in the U.S. is that competition is happening at the wrong level. So there is a zero-sum battle over things like bargaining power, network size, and cost shifting, rather than really on better patient outcomes. That's not, outcomes is not the main driver. It's these other things. And so they define in their book value as outcomes over cost. So better outcomes, less cost, more value, right? And the core principles of really driving this value-based competition is to, one, focus on this value, compete on results, and to really organize competition by medical condition across the full cycle of care. So the whole emphasis here is that we should really be focusing on the disease and not the specialty. So which is what we do now. We build by specialty, we're organized by specialty. But like, for example, you take diabetes, right? Somebody who's diabetic, it crosses multiple specialties, and each of them are kind of siloed, and each of them get a little bit of the pie in terms of managing that patient and also the payment for that. But we're not really looking at that patient potentially globally as a diabetic patient. How are they doing? And ideally, if you really have high quality care, it should ultimately lower, not raise costs, right? Because if you keep people healthy, then they're going to cost the system less. And we should really compete on a regional and national level, not just locally. Healthcare is very, very local, which patients do appreciate, but their argument is that sometimes, especially with more rare diseases and tertiary quaternary care, you should centralize that care and then kind of show your results and get people to see the outcomes they can get if they go to a specialized center. And that would actually ultimately save the country money. And so you want to make results, prices transparent, and then reward innovation. And the question is, how do we actually go in that direction? And so one thing that the book talks about is to organize on what they call integrated practice units. So, you should sort of, again, build around a disease, a condition with multiple specialties and own that sort of process from beginning to end, from prevention of disease to treatment to follow-up and rehab. And we should also measure the outcomes over the true full cycle of care. That is risk adjusted, because patients coming in with different risks will make things harder potentially to manage, right? And then payment should be distributed in this bundled format where you pay for the full cycle of care. So you get one payment to manage that patient. So you can imagine that system, you would get more upside if you did well, right, and kept the patient healthy, and you would do poorly if there were a lot of expenses involved, a lot of hospitalizations, readmissions, then you would lose out. And this has kind of been adopted over time. AMA now defines value as outcomes plus safety plus service over total cost of spending. So service meaning the patient satisfaction scores, obviously patient safety here. And so turning this sort of this theory into policy has led to this timeline here, which I'll go over, of where U.S. policy is headed, right, in terms of federal policy for Medicare, or CMS. And we'll go through each of these. So there's a jump I just want to point out between 1983 and 2006. There was not a whole lot of policy in value-based care. And that's because sort of, not shown here, but another timeline that I want you to all think about in the back of your head is in 1973, the HMO Act was passed. I don't know if you guys are aware of this. So Nixon passes the HMO Act. It basically, at that time, they already knew that costs were going up too high. They realized that by providing HMOs, which is a capitated model of care, right? You give a lump sum and you say, take care of the patient, that's all the money you get, that they could cut down on cost. And with that act, what they basically pressured employers to do was to offer an HMO option to all their employees. So all the employees, all the plans had to have some HMO option. And it pushed a lot of patients into an HMO model. And that did drive down cost, but there was a significant backlash that happened, especially in the 90s, where there were such narrow networks. People were being denied care because they said it wasn't needed. And so patients were feeling it, employers were feeling the complaints from their patients, and ultimately that kind of fell apart. And so there wasn't a lot done until about 2006, when costs started going up again and policy had to be made to adjust for that. So that's the background. So in 1983, there was the Medicare prospective payment, which put in this DRGs, right, which is where you as a hospital, you get paid a flat fee per diagnosis instead of billing for each service. And so this definitely incentivized efficiency basically towards shorter hospital stays, right? Because the shorter you stay, the more you're going to keep, right? The longer the patient stays, it doesn't matter. You get the same payment no matter what. For us as a specialty, it meant shifting many of our procedures nowadays, which we think of as routine, to outpatient surgery, right? So tonsillectomy, thyroidectomy, sinus surgery, those are all same-day discharges now, right? And then part of it is, you can also, it's safe for patients and it's good for them to be at home, but a lot of it's also policy driven. And hospitals applying pressure on specialties like ours to minimize the length of stay. Just as an anecdote, my au pair from Germany recently had her thyroid removed there for hyperthyroidism. And she stayed 2 nights in the hospital. And she said, oh, that's new. The doctors told me they used to keep them a week, but now I'm only staying 2 days. So, other countries have a very different sort of system because they're not driven in this way, policy-wise. And then, fast forward time, remember the HMO period I talked about, kind of the backlash in the 90s, so not a whole lot happened with CMS, but, prices kept going up, expenses going up, so things had to be done. So in 2006, the Physician Quality Reporting System was developed. This was a rewarding and penalizing system that Medicare developed where they were asking for quality measures. So jumping the gun a little bit, but what that whole HMO saga led CMS to realize and the country to realize is that you can't just try to drive costs down by capitating the system. You also need to figure out ways to drive up quality and to drive and improve patient experience. And that's going to be where you get buy-in from everybody. And so this was sort of dabbling at that, was saying, okay, how can we get quality measures reported to us so we know what's actually going on? What are we actually paying for? And this was really just a small drop in the bucket. So I took this data from our Academy website. In 2011, they collected data from physicians in our specialty, and they found that 21% of all eligible otolaryngologists at the time were participating. So not a huge amount, 1,800. And by participating and reporting quality measures, on average, each physician got about $1,200 in financial reward. So for our specialty that year, it was a $1.7 million distribution. So very low numbers, right? I mean, it's something, but this isn't going to move the needle. But it was something. The top things that people did to get rewarded for this was EHR adoption, medlist documentation, tobacco screening, and otitis externa management, actually. Then the ACA comes around, Affordable Care Act, right? So the main policy here when it comes in this bill that really falls in the value-based care payment models is creation of accountable care organizations. So sort of in simple terms, an ACO is where a group of doctors or hospital decide that they're going to keep a group of patients that are basically their patients, their population, healthy. And when they take on this population that's attributed to their system, and there is savings involved and improved quality, then they get an upside to that, right? So there's reward for doing well in this model. And now we're also introducing, you'll see in the coming years, probably downside risk as well, meaning you probably will have to pay back money if you don't do well. In the beginning, how it started was just that you benefit from upside. And I was actually trying to find out if we're part of an ACO here at Stanford, and I believe SMP is here, part of the Medicare, what is it, MSS? I forgot. There's an accountable care organization that you can join through Medicare, which I believe our partners are part of. So in the ACA, the other two things that really, I think, impacted our specialty in particular was the readmissions reduction program, which is where we started experiencing penalties as a health system if patients are coming back within 30 days after care, right? So for us, that's post-surgical readmission. And then hospital value-based purchasing, which is where your bonuses and penalties are paid based on outcomes, infections rates, patient satisfaction. So for us, again, this is where now we're looking at our post-surgical readmissions are directly affecting hospital penalties, where we're also getting pulled into potentially ACOs to help with care coordination efforts. And there's greater pressure for just outcome tracking and reducing complications in general. And then in 2015, there's MACRA, so the Medicare Access and CHIP Reauthorization Act, This is a pay-for-performance model. It created 2 tracks of payment, right? MIPS, which I'm sure a lot of you are familiar with in this room, and then APMs, alternative payment models. So MIPS you can think of as like a report card, right? Where there's several things you have to report on as a health system that were scored on quality, cost, technology use, practice improvement. And then APMs are basically ways you can get payment where you can do sort of cost savings together with the insurer, in this case CMS, and then if there is savings at the end of it, you get a distribution of that. And so you get some of the upside. So the difference between MIPS and APMs, in the MIPS model, the merit-based incentive payments, which is largely what ENTs have to do, one is you are automatically enrolled, okay, if you see a certain number of Medicare patients. So this is not something you can choose. So you're enrolled if you're seeing Medicare patients. 2, unfortunately, it's a zero-sum game. So meaning that if you do well on your report card as a health system and you get a 9% bonus, let's say, on your performance, that means another healthcare system is losing out on 9%, right? Because it's a budget-neutral system. So at the end of the day, the money is already been pre-allocated, and you're going to get, there's not going to be any extra in that. And that payment, you see, oddly, is actually 2 years later, right? So if something happens now in 2025 and we do well, you see that payment in 2027. That's how MIPS works. The alternative payment model, though, the nice thing about that is not a zero-sum game. So if there is overall savings for the group, for certain procedures, for example, then you get some of that upside. So, because if you're saving the federal government money, then you're going to get a percentage of that savings. So most folks would actually, I think, probably prefer more of this type of model than a zero-sum game, ultimately. And so for us right now as a specialty, we're basically required to participate in these MIPS reporting. The hard part about this, too, is the quality scores that they're looking at. There's certain things you can report on, are often generic. They're not really to our specialty in particular, so that's also hard. So a lot of times, for example, people will pick things like this tobacco screening or something like that. It's really like primary care metrics, but we're trying to grapple with something that has some relevance to otolaryngology that we can report on. And so our academy, for example, is trying to develop these registries, like I think it's called Reagent. I don't know how to pronounce it, but it's a quality tracker to help us figure out our own metrics that we can track as a specialty versus using generic ones that we have to report. But this is, again, it's opening the door for us as a specialty in the future to participate in these bundled and risk-based contracts. So there's a lot on this slide. Basically, between 2016 and going through 2026, what's happening is there's several bills that have been passed that are shifting care to a bundled payment system. It hasn't hit otolaryngology specifically yet, but they're kind of paving the way, right? Right now, they're targeting more expensive care, basically. So cancer care, joint replacement. There's also some primary care policies in there. But the goal is to come up with bundled payments. So you get one payment for that care, and so the healthier you can have the patient, the better the outcome, the more savings you're going to have, right? You're going to cost the system less. And in 2026, the team transforming episode accountability model is the biggest, I'd say, policy in terms of crossing multiple surgical specialties and bundled payments. So it's a mandatory surgical bundles for joint replacement, hip fracture, spinal fusion, CABG, and major bowel surgery. Again, otolaryngology is not on there yet, but you can see the direction this is going in, right? And you can say, well, this is all CMS, right? This is all just Medicare. That's only a small portion of our patients. What if I'm mainly seeing a commercial patients, right? Patients from commercial insurers. The thing is, Medicare, it's a ripple effect, right? It sort of sets the standard for our country. Whatever Medicare is dictating, you're going to get state level Medicaid buy-in as well, and they're going to have their own similar programs. Commercial insurance will also look at this and start developing this. And then employers are going to start demanding value-based coverage. And so this is sort of the direction the whole country is going towards. And it's interesting, there's actually some literature in our field about, can we do bundled payments in otolaryngology? What does that look like? And one of the first papers out there is from MD Anderson. It was a 1-year pilot. They partnered with United Healthcare. And what they did was they came up with a risk-adjusted bundled payment for head and neck cancer. And the way they did the payment was not so much on the type of cancer, because there's different treatment modalities, right? So it's kind of hard to say, for all tongue cancer, it's this payment. That doesn't really work. So what they did was they paid based on the modality. So if it was single modality versus multimodal treatment, you get different bundled payments. And they enrolled 88 patients over this 2-year period of this pilot. The physicians were blinded to who was in this bundled payment model and who wasn't, so to try to eliminate bias there of how they treated the patients. And what the study found in its pilot phase, and it kind of died after that, was just that it is feasible. You could do this. You could come up with a way to do bundled payments. However, because of complexities of head and neck cancer care, and also the system was really built for fee-for-service, it required a lot of administrative staff to do this well. So to submit the payments, for example, and capture, who was in this bundled model and what care counted as part of this bundled payment and what didn't, that required an additional 2.5 FTEs from the MD Anderson side the first year of the pilot, and then 1.5 FTEs for the second year. And this is just for 88 patients. So you can see that the question is, does this really save anybody any money, right? That the goal is, are we really increasing quality and saving money by doing this? That is not answered by this study. And the other downside, too, is that United Healthcare required more time in processing the claims. And so that it sort of interferes with your payment cycle time, too, your hospital. So you're not getting paid for longer as they process the claims. So questionable how much this is going to benefit our specialty. But one state did this for the entire state on the opposite end of the spectrum, something much more simple, which is TNAs. And they did have some better luck. So Arkansas, they did actually bundled payments for their entire state. So it was mandatory. Everyone had to enroll in this program. Anybody getting a tonsillectomy and adenoidectomy was in this bundled payment model. And it covered the cost from initial consultation to postoperative day 30. And it has specific quality metrics they were trying to get the physicians to meet as well, like intraoperative steroid use, not giving antibiotics post-op, things like that. And also bleed rates, too, looking at the rate of hemorrhage post-op. And their initiative actually did show some good outcomes. So between 2013 and 2015, when this was adopted, there were 11,000 tonsillectomies, adenoidectomies done, predominantly Medicaid population, 83%. And the mean risk-adjusted cost per episode actually decreased by 7% per patient. So there was a cost savings there. And there was some improvement in quality metrics. So there was a relative reduction in the following, which was 48% decline in surgical pathology use, 83% decline in postoperative antibiotic use, and 56% decline in post-op bleeding, interestingly. And so in this system, the 96% of the otolaryngologists were eligible for some gain sharing with Medicaid, which means they got some of the extra money and redistributed to them with the savings, and it equaled about $1,800 per physician. So this did show there's some, you can have some success here with a model like this. And so sort of the remaining time, the next 30 minutes, I want to kind of share with you what I've learned personally in the world I lived in for the 10 years that I was at Kaiser Permanente, and show you the things we try to do there along these lines. I would say, this, so if you're not sure what the Kaiser model is, it's an HMO model. It's one of the oldest in the country. It was around before that 1973 Act. So it's a capitated model, which means the system gets a payment per member per month, right? So you get upfront payment, you take that payment from the insurer, and whatever happens to that patient, that's the amount you get, right? So it behooves you to keep the patient healthy and not sick, right? And to reduce complications and things, because all those will lead to further costs for your system. And so the benefit of being in that model, I would say, is if I wanted to do pilots and look at ways to change the model for better quality care, I didn't have to worry about things like reimbursement. So that was nice. And there was institutional alignment in generally with doing these projects and driving down cost. And also, the really nice thing is that when you have a closed system like this, you have complete patient records. So you're able to track patients much easier. You don't have records elsewhere. They're all in the system. It's easy to do data analysis there. The challenge, I would say, and I think that's everywhere, even in the fee-for-service world, is when you do a project looking at value-based care, how do you show the administration what you're doing is leading to true cost savings and there's a return on investment? That's the question. And then getting buy-in from others. Whenever you have to collaborate with others, you're going to get what's in it for me. And so you kind of have to break those barriers. And then capturing informative data has been a challenge. Even though the system that I worked in was closed and you had all this data, things like patient-reported outcomes, which is going to be a huge thing for us, right, as ENTs, because our specialty relies so much on quality of life and more subjective measures, is how do you get proms to get filled out? We would send them electronically to patients, but less than 10% would respond. That's the challenge you face. And then always advocating for limited resources. So this is a project I did right before I left, where the problem I saw as a physician there was that the pediatricians, primary care docs, whenever they saw patients with an ear problem, and they would call us on our consult line and try to describe the ear, I had no idea what they were seeing. It's really hard, right, to describe an ear exam, especially by somebody who is not an otologist or otolaryngologist, and then try to come up with suggestions now as a consulting physician what you should do with them on the other line. And so my initial thought was, can we get cameras into the office, right? Can they get a digital otoscope, take a picture, and then have that in the chart and have us review that beforehand or even in real time to help them out? And so it led to this pilot. But actually, we found much more than that. So all I did was got these digital otoscopes into our pediatric offices in the San Francisco clinic and let the pediatricians use it. And so there's a group of patients where this was being used on, and then a group that was just getting their routine care without the digital otoscope. And when I looked at the average number of visits per patient, when you compare those where the digital otoscope was used, which is the orange, and those where it wasn't, the blue, you see the average number of visits per patient for an ear complaint went down. It went to 1 for those where the digital otoscope was used, and more than that if it wasn't. And the implication here is that if you can see the eardrum well, look at it, get consultation on it real time from an ENT, and talk to the patient about it with them looking at it, you can probably decrease need for return visits, right? And then the antibiotic use one was really interesting. So we looked at the number of antibiotic orders per patient for ear complaints, specifically patients coming in for acute otitis media in the pediatric world. And you can see the percentage went down with the digital otoscope use. So these patients were not getting antibiotics as much as those when the regular otoscope was used. Yeah.
So for each of these patients, do they have a phone consultation with an ENT?
No, most didn't. So my personal interest in this was to help with that, because we wanted to be able to actually help them. And I thought if I can get an image of the ear, we can better communicate with them and help them. But we found actually once they saw the ear, they didn't need to call us. They were just doing it. They were just looking at the pictures and using it. Nobody was calling us. It was actually pretty rare.
So you thought they got a better exam?
I think so. That's my opinion. I don't know, right? But that's my sense, is that they probably got a better exam, because we weren't actually getting called that much at all. But we saw this trend. And this is just survey responses from the patients after the visits. And the text is kind of small. But what it's showing is that the vast majority of patients found this to be quite helpful during their visit. They found it educational and beneficial to them as a patient's perspective, to have a picture of the ear to look at. And then this was just some feedback we got from the physicians about the benefits of a digital otoscope. And they found improved visualization of the ear, enhanced ability to store images in the chart, easier sharing of the exam findings with the patients or a colleague, and time savings during the exams. So that's one area that I think you can see where you can definitely add value with technology and actually reduce cost and improve quality, I hope. So another project I did while I was there was trying to reduce unnecessary opioid prescribing. And so the impetus was this is that I could actually, as chief and chair, get data on exactly how much opioids we were prescribing as a specialty from our pharmacy. Again, because we're a closed system, including with pharmacy, I could see that data, like how, what were we doing with opioids? And what I found was, one, we were prescribing a lot. And two, when you surveyed the patients, most of them said they were not using them all, right? They were largely dispensing of this. And so we came up with a standardized protocol to try to reduce unnecessary opioid prescribing. And the intervention was basically to push acetaminophen and ibuprofen, right? Multimodal analgesia, decrease opioids. Our recommendation to everybody was to, if you're going to prescribe an opioid, do it 15 tabs at most. And everyone was often doing this 25, 30 tabs kind of thing. And so if you really felt your patient needed opioids, limit it to 15 tabs. And so we saw after our intervention, and we made it easy by ultimately coupling with the EHR. So in the post-op order set, when you go to order pain meds now, you have all these options. And you just have to click for the patient to get the medication. You don't have to write the script yourself. You can just pick the bundle, right? That'll have the Tylenol and ibuprofen in there with even the instructions on how to alternate the two for pain control, and then the opioid too that has less tablets. But in this pilot phase, what we found is by introducing this idea to the otolaryngologists, we went from basically 0% of patients getting no opioids post-op to 41%. And the opioid tablets prescription didn't go down to 15, but it went from 24 on average to 18 tablets. Acetaminophen use went up by 71%. Ibuprofen use went up 113%. And the patient pain scores didn't change post-op. It's not like they had any more pain now because we changed this. And so this kind of just shows that you can, as a group, through standardization, leveraging the EMR, really protocolize more some of the care we deliver and decrease some unnecessary use of things like opioids. And then lastly, this is an example of showing how, if you get your subspecialists to work together to help your comprehensive otolaryngologists and primary care docs, you can really help try to improve the care delivery on a whole system level. So what we did here is a lot of work on sudden sensorineural hearing loss when I was there. As we all know, this is basically an otologic emergency, right? And it behooves us to recognize the condition quickly and get corticosteroids in them quickly to be able to have a good outcome with their hearing. And so what we did was, with the otology work group, which is a bunch of otologists in the system, come up with a protocol to help, one, get our primary care docs on, to recognize this condition, and also get them to quickly prescribe the correct prednisone dosages. So two things were happening. One, it wasn't getting recognized, but also when it was recognized, the prednisone course being prescribed was not adequate, right? It might be a little medral dose pack, it might be 20 milligrams of prednisone for 5 days. All sorts of weird prescriptions were happening. And so we were trying to figure out how to get this standardized to fit our academy guidelines. And so first we predefined the corticosteroid protocol that was defined by our academy. That also included intratympanic steroid injections. We put advice on all of our consult pages to primary care docs whenever they went to the section regarding hearing loss. We had open spots daily on our audiology schedules to make room for any of the sudden hearing loss patients. And we provided same-day access or next-day access to any patient where the audiologist picked up sudden hearing loss. And so this is not meant for you to read, but this was basically the protocol. It's published of what we recommended for treatment. And we did separate, mild to moderate versus severe to profound sensorineural hearing loss because we added the caveat of hyperbaric oxygen therapy there to the more severe hearing loss patients. And we also had a protocol of when to do the audiograms and all that. And, obviously emphasizing MRI too and making sure they were getting that. So what we found in our population, this is 1 year of data after this was put in place, is that we had 403 patients present with sudden sensorineural hearing loss in our system. 88% received corticosteroid therapy, 76% within 14 days. And the the steroid initiation within 14 days was significantly associated with improved audiologic response and recovery compared to no steroids, as we know. And it's to sort of put this into space of like, what does it look like compared to other systems? Here I found 2 papers looking at population-based studies on sudden sensory neurohearing loss, and you can see I think we did pretty well compared to some of the other systems here. At the bottom there is the Department of Defense, and so they have more of a closed system like us. So they looked at their patients with sudden sensory neurohearing loss. They did really well with average time to presentation. They found 4.9 days patients were average presenting to primary care or ED, and they were able to recognize the problem. But it took 15.3 days to get to an ENT and 14.2 days to an audiologist. So still not really in that 2-week window of initiating treatment. And then in this Metro Health Michigan system, unfortunately, it wasn't so great. You know, on average time of presentation for a patient was 55 days, and time to treatment was in ENT was about 36 days. And so really many patients were presenting quite late. So we can do better than this, right, as a system. And some other things just want to touch upon briefly about what we try to work on while I was there is hearing screening. So we had an AMTAS pilot. I don't know if you guys heard of AMTAS. It's from GSI. It's a hearing screening tool. It's quite nice now. I can give a whole talk about, and I'm not an otologist, but about how I think we're really behind with audiologic testing. I mean, I think that this idea of building a soundproof booth and the resources involved in doing that is not helping the masses with hearing screening and really diagnosing, treating hearing loss. It's just it becomes such a limited resource. And these days, with the amazing headphones we have with noise cancellation, I think we can mimic that without all the resources needed to build these booths. But anyways, AMTAS, the system is like that. It uses really good hearing headphones, and you can do either a screen or a full audiogram that's automated. And you can get the results, and you can really it helps you guide care in that way when you can't have access to an audiologist quickly. So we were piloting that while I was there. And also, one thing we were in charge of for otolaryngology there was temporal artery biopsies, and how do we get them in the system sooner for biopsies so we don't miss those. And that's just, working on these pilots taught me you have to do so much coordination among other specialties. We have to talk to our colleagues. What I learned from that pilot is we can't just be the driver there. It has to be rheumatology driving this, ophthalmology, even primary care. And then it's also even talking to pathology and making sure we get those results quickly in time and things like that. And so whenever we talk about doing a project in our specialty, we've got to sort of reach beyond our own walls. And another good example is peritonsillar abscesses. We were trying to reduce the number of return ER visits for those patients. How do we if they come in once, how do we not have them come back again to the ER? And so that was a lot of coordination with our emergency room physicians, but it can be done. And another thing that I actually brought over to Kaiser from my days at Sinai was bedside tracheostomies. Bringing a patient from the ICU down to the OR to do it was challenging. We all face that here. The time it takes to bring them down, finding block time for those patients, and they're just getting pushed down, delayed, and getting their trachs. And so COVID was the best time to actually initiate this pilot, which was, can we bring the trachs to the bedside in the ICU? We were able to do that. And that way you can get the trachs done, many of them in a day, actually, at the bedside, and not having to involve the whole OR space and staff. So, in summary, I think what I've learned over the years there is that when you look at value-based care and trying to improve quality, otolaryngology is tough. We focus a lot of the stuff, especially the outpatient stuff, right? It's on quality of life. There's not a mortality associated with it. And so how do we measure quality of life in our patients? And we have really limited specialty-specific metrics. Other than patient-reported outcomes, I think I'm a bit at a loss of what are we tracking for our patients. And then the data collection burden. If we're going to really rely on PROMs, how do we do that? Because patients don't fill out these surveys. They just don't. And so how do we look at that? And then the other problem that we all face is we do a lot of small case volumes and very specific things with a lot of high variability. It's easy to target joint replacement, right? Hip replacement, knee replacement. But as you know, all of us, our practices, we do 10 cases of this here and 5 cases of that there and 3 cases of that there in a year. And they're all very different. And what does that mean? How do we track meaningful quality measures when there's so few cases that have the same sort of qualities? And so the last little bit I want to spend is just on how I think we could potentially do this, and lessons I saw in the literature potentially that could guide a health system as big as Stanford in maybe doing this more globally. So this paper comes from the University of Utah Health System. Vivian Lee there at the time was the CEO, and she implemented value-driven outcomes to reduce costs but improve quality. So what they did was they identified cost variability and reduced expenses by reducing that variability. And what they did was first, they wanted to track what was being spent and how it was being spent. So first, they defined cost to the system. And so, you can think about cost as cost for the patient, cost for the payer, but for this purpose, they're saying, okay, how much does it actually cost us for this patient coming in our system? Not the charges that they were putting out there, but what did it actually cost the hospital? And so they looked at facility utilization, imaging, lab testing, therapy services. And with the provider side, they either used RVUs or if there was no RVUs, like if it was a tech's hourly rate, they would just calculate how many hours that patient was in the MRI, right, versus how much the tech is being paid per hour, that kind of thing, to figure out in detail how much it costs to deliver care. And then what they did was define outcomes how they felt it should be defined. So they use quality metrics that we all use, like hospital-acquired infections, unexpected readmissions, patient satisfaction, PROMs. But beyond that, for every service line, she asked them to define what perfect care meant to them. And a lot of these were processes, not necessarily outcomes, but it was a step in the right direction, right? So it's thinking, okay, if a patient hits all of this, if that patient got perfect care in our system. So as an example here, in their paper, they show you what they did for CABG, hip fracture, colectomy. So if you look at CABG here, if a patient hit all of these metrics, so getting antibiotics, using the internal mammary artery when appropriate, cumulative post-op mechanical ventilation less than 24 hours, no reintubation in the post-op period, so on. If a patient hit all of this, it was considered getting perfect care in their system. And then what happened is they developed this scorecard. So for every patient actually was tracked in this way. So they had their surgery information, their tracker of whether or not they hit all the metrics that the service line defined, and then the exact cost breakdown. And then you as a physician would get your scorecard and you would see what happened to my patients. How much did it cost the system? And did I hit these perfect care markers? And what they found was that once they actually did that and gave the scorecards out to physicians, just having that data really empowered them. The orthopedic surgeons, for example, went from 50-something% of hitting their scorecards to now 80-something% of a perfect visit, a perfect surgery, if you will. And they were able to, by actually making the data transparent, find areas where there was huge variables and costs without any meaningful outcomes that justify it. So an example they gave with orthopedics is the implants, right? They used all these different implants. They didn't have great contracts with any of these companies, and so they lost a lot on savings there. When they got the surgeons to all agree on only 1 or 2 implants instead of all these different implants, they got to negotiate a much better contract with the companies, reduce costs, and the quality really didn't change. I mean, the patient's outcomes were as they were. And another one that was interesting with orthopedics, they describe in the paper, is they found through their studies that one of the big factors in getting the patients out of the hospital and not getting readmitted and having good outcome was early ambulation, right? Getting them out of bed, moving their new hip or whatever. But one of the biggest barriers was actually the shifts of the PTs. By the time the patients came out of the OR and was ready for some immediate rehab, the PTs had gone home. And so they just shifted the schedule, and they realized by doing that, it saved the hospital actually a ton of money because they could get the patients out of the hospital the next day and doing better. And by actually having that data with those scorecards, they found those opportunities. Because that's, I think, a lot of the problem is we don't know where the opportunities lie if we don't have the data. So I think, just looking into the future, but what we can do as a specialty, I think we have to do problem-driven innovation, meaning we have to actually identify true problems. And we tend to, I think, oftentimes jump to solutions without understanding the problem. We have to find meaningful outcomes for our specialty. So what does it mean to have maybe the perfect score for us as a specialty? And there's a lot of new technology and new tools spreading rapidly, but we have to sort of make sure we adopt that with evidence. I'm alluding to the balloon sinuplasty thing I presented at the beginning. So there's great devices that are out there that can cost a lot of money, but is it really helping our patients? And really trying to reduce low-value care. So we really want to curb unnecessary imaging, right, and testing and procedures that add costs without improving outcomes. So sort of in conclusion, I think we all know this. Our current spending is just unsustainable. I think value-based care is here to stay. It's not going away. We're going more and more in this direction. And the policy evolution is showing that. And I think for specialties like us, it's really about bundled payments. That's how they're going to kind of curb cost in the surgical field. And I think in our specific field, we have to come up with something beyond the generic measures that CMS is telling us right now. And that's going to be probably through our academy and advocacy groups for us. And that if we do pilots like the ones that they did in Arkansas and the ones they did at MD Anderson, we can sort of show how value-based care might be accomplished in ENT and drive the discussion ourselves rather than letting others tell us what we need to do. But yeah, there's still lots that challenges that remain. And I hope that we as a specialty start to think about what we can do rather than being a bystander in all of this. But thank you. Question? Yeah.
So really, really great talk. I'm Florida with
Yeah.
but so I was interested in sustainability, and I just wanted to draw the parallel between in sustainability as well. There's a focus on let's avoid that low value care, and oftentimes where the money goes, also the carbon emissions go. And so I think, of course, we have to be compliant as physicians with whatever policies are coming down on us, but it can be a good motivator as well. Like saving a little bit of money, maybe not as motivating because it doesn't directly affect a salaried physician, but being more sustainable, I think, is a positive message. And so
Yes.
those things do go in the same direction.
100%, for sure, yeah. Because the waste is not just dollar waste. It's material waste, it's energy waste for the whole
Yes.
system.
Well,
Sure.
the thing you bought, has this whole footprint.
Correct.
From before you
Correct.
and after you. And so when you're saving those dollars on the test or the equipment, you're also saving the carbon emissions.
100%, yeah.
Melissa Smith, I'm one of the pediatric otolaryngologists. With this big move towards outcomes, do you ever worry that patients that are sicker, that are more high risk, are going to have trouble accessing care because people that are close to them that are able to select their patients aren't going to be willing to take them on?
Yes, that's the big fear, right? Is that people who are sick, they're not going to take them on. So that's where there's a whole emphasis on risk adjustment. But you have to do it well, though. That you have to really properly apply risk-adjusted models to these patients to say, okay, well, taking on this patient does mean that they are riskier, that they're going to cost the system more, and we need to be able to have those resources. So if you've done well, yes. That's the huge fear, is that if you do this, then people will more cherry pick their cases, and that's the last thing we need. It actually goes hand in hand with health insurance these days. If you think about the insurer's perspective, right, this is their conundrum. On average, patients probably stay with their insurance, 3-4 years, right? They often switch. They shop for, just as much as they doctor shop, they shop for insurance coverage too. So why would an insurance company care to spend so much money, for example, on a potentially life-saving drug for you now, so that, let's say, you live longer and you cost the system less 20 years from now, when you're not going to maybe even be one of their beneficiaries, right? Or one of their covered members, that you're just in that system for 3 years. So it's hard to say, okay, I'm going to spend upfront money now to save the system later, the system globally, right, or as a country. And so yeah, I think that we have a lot to think about in terms of payment reform, because if we have that and patients just switch in and out of insurance plans, they have no incentive either to think about the upfront costs that they would need to put in.
That's a really interesting concept, especially in light of the fact that they can anticipate that most people will go on to Medicare, if Medicare still exists, by age 65, when morbidity and comorbidity increases. Yeah.
That's right. That's right. They want to. I mean, for an insurer, they want to cover the person when they're youngest, healthiest, and don't need health care.
Mm-hmm.
Right?
Right.
That's the best time, and charge a ton of money. So the employers pay a ton of money for these employees who never see a doctor. That would be ideal.
Maybe a quick European comment, because during the MBA we looked at different healthcare systems, and Kaiser actually was one of the systems that we also discussed in Europe because it was so innovative at the time. So Germany does have a DRG model as well, for example. It was started decades ago, but the system is not just reimbursing for the surgery itself, but also for the inpatient stay afterwards. And so you always, for every surgery, you want to be right below that sweet spot, basically, because so for the thyroidectomy, for example, if it's a 2-day stay, the hospital still gets an additional payment for that second day in the hospital. So and those times are determined by the national averages. So you just want to be slightly below the national average, so you maximize the payment that the hospital system gets, but you still kind of make money off of it.
Yeah. So you see, the thing is universal, right? And when people go up there and say, "Well, Europe's doing it better," it's just that it's not necessarily. At the end of the day, unfortunately, as the world works, the dollar drives the behavior.
It just still seems like there's such a huge difference between the U.S. and every other country. And I mean, I know it's looked at, but what do I?
Yeah.
Yeah. What do you
I think it's much more beyond us. I'll say, for example, the other day I kind of got upset when I heard it. I think it was Bill Maher on TV talking about RFK Jr. and he said, when I went to the doctor and they asked me all these questions, not one time did they ask me, "What do I eat?" Diet is such a big part of our health. And I just think that's wrong in our health system. And I agree that 100% diet is a huge part, and exercise. And yeah, a lot of our country is obese, morbidly obese, much more so than these other countries. And we have these food deserts, and people are going to the 7-Eleven and getting a bag of chips, versus developing countries even where there's still lots of fresh fruit and vegetables, right, in the market just down the street. And we have that huge problem. But I don't think the healthcare system can fix that. I don't think the primary care doctor talking to you for 10 minutes about healthy eating, unfortunately, is going to change that. It's going to take a lot more than that. And so I think just putting it on the doctor isn't the right answer. Yeah. I just think, recently, I think when you travel, you really see this, right? I just recently was in Colombia, and yeah, it's a developing country. They have problems that, socially and economically, but it's a beautiful country, and the food there is incredible. And no matter what small town you went to, they had these fresh markets in the town center with amazing fresh fruit and vegetables, fresh juices, right? They had literally went and picked that fruit earlier that day, probably brought it down, and they squeeze it for you to drink. And that's what their diet is. And here we don't have that at all. It's really sad, right? Our patients are going and eating ramen, in these food deserts because it's cheap, and Cheetos and whatever because it's cheap. And that fresh juice from Jamba Juice costs us $10, right? And that's what we live in, and I think that's a huge part of that. So I think, I still think, obviously I'm biased, the U.S. healthcare system is the best in the world. People come from all over the world to get healthcare here if they have the resources. There's a reason behind that. It's not because we have poor care, right? It's because people know this is the most innovative country and delivers some of the best care. But unfortunately, for the masses, for a population perspective, we do so much to inhibit people from being healthy here.
Yeah. Well, and also access for
correct,
this
yes.
segment of population that can't get their prenatal care.
Yes. So we have amazing care for those who can access it and who have amazing insurance. If you have a great PPO here, I mean, the world's your oyster. You can go anywhere and get the best care, right? But that's not most folks. And that's the problem. Yeah.
All right, it is now 8:01.
Yeah.
Nancy, thank you so much for distilling a very challenging topic into a 1-hour clear presentation. Thank you so much.
Thank you all.